The brain receives blood from two main sources: the internal carotid arteries anteriorly and the vertebral arteries posteriorly. As you see in this image, these vessels connect at the base of the brain to form the circle of Willis. This circle is an important anastomotic ring that provides collateral circulation. The anterior circulation includes the anterior cerebral artery and middle cerebral artery, which branch from the internal carotid artery. The posterior circulation includes the posterior cerebral artery, which branches from the basilar artery formed by the two vertebral arteries. Understanding this arrangement helps us predict which symptoms will occur when a specific artery is blocked. Now let's go through each arterial territory and its clinical presentation. Let's start with the anterior cerebral artery. As you can see in this image, the ACA supplies the medial surface of the frontal and parietal lobes. For motor symptoms, you'll see contralateral weakness affecting the leg much more than the arm and face. For sensory symptoms, there's contralateral sensory loss, again with the leg more affected than the arm. Other important features include urinary incontinence, abulia, which is a lack of motivation or will, and frontal lobe signs. Now, let's discuss the middle cerebral artery, which is the most commonly affected artery in a stroke. The MCA has superior and inferior divisions, and we need to understand each separately. The superior division causes contralateral weakness, affecting the face and arm more than the leg. If the dominant hemisphere is affected, you'll see Broca's aphasia. An important sign is that the eyes deviate toward the lesion. The inferior division presents differently. If the dominant hemisphere is affected, you'll see Wernicke's aphasia. There's contralateral sensory loss. In non-dominant hemisphere lesions, you'll see neglect syndrome and anosognosia, which is unawareness of the deficit. When there's complete MCA occlusion, you get the combined features. This includes contralateral hemiplegia, with face and arm more affected than leg, contralateral hemianesthesia, homonymous hemianopsia, and global aphasia if the dominant hemisphere is involved. The posterior cerebral artery supplies the occipital lobe and parts of the temporal lobe. There are two main patterns: cortical PCA and thalamic branches. As shown in this image, cortical PCA stroke affects vision. You will see homonymous hemianopsia with macular sparing. Other features include visual agnosia, prosopagnosia, which is inability to recognize faces, and if bilateral, cortical blindness. When thalamic branches are affected, you get contralateral sensory loss affecting all modalities. This can lead to thalamic pain syndrome. There's also memory impairment. The vertebrobasilar system supplies the brain stem and cerebellum. Let's discuss the key syndromes. PICA stroke causes lateral medullary syndrome, also called Wallenberg syndrome. The key is remembering ipsilateral versus contralateral signs. Ipsilaterally, you get Horner's syndrome, ataxia, facial pain and temperature loss, and dysphagia. Contralaterally, you get body pain and temperature loss. Basilar artery occlusion is severe. It can cause locked-in syndrome, diplopia, dysarthria, dysphagia, bilateral motor weakness, and altered consciousness. Cerebellar strokes present with ataxia, vertigo, with nausea and vomiting, and nystagmus. An important complication is risk of brain stem compression. Finally, let's cover lacunar syndromes. These are small vessel strokes with classic presentations. Pure motor stroke is located in the internal capsule or pons. These deep structures carry motor fibers. The presentation is face, arm, and leg weakness that are equal. Importantly, there are no sensory signs and no cortical signs. Pure sensory stroke is of the thalamus, specifically the VPL nucleus. You get contralateral numbness affecting all sensory modalities. We see ataxic hemiparesis when pons or internal capsule is affected. This presents with weakness plus ipsilateral ataxia. Dysarthria clumsy hand, again in the pons. This presents with facial weakness, dysarthria, and hand clumsiness. To summarize, Understanding arterial territories helps you predict a stroke presentation. ACA affects the leg more than arm. MCA affects face and arm more than leg. PCA causes visual deficits. Vertebrobasilar affects the brainstem and cerebellum, and lacunar strokes present with classic pure syndromes. Knowing these patterns is essential for localizing lesions and managing stroke patients. Thank you for watching. If you found this helpful, please like and subscribe to Mindmap Academy. Also, visit our website to take the related quiz.